This is a technique video of a battered shoulder with a posterior labral repair with knotless retensionable suture anchors. And here are our disclosures. The patient is a 20-year-old male who felt pain while batting 12 weeks ago. He had a hard time throwing the baseball, particularly on the follow-through. On physical exam, he has full active and passive range of motion. He has 5 out of 5 strength in the supraspinatus, infraspinatus, and subscapularis. He has non-tendon palpation over the biceps tendon. There is a negative Neer and Hawkins test and a negative O'Brien's test. He had a positive Kim and Jerk test, and 0 out of 9 Baton criteria. On MRI, a posterior labral tear was noted. The patient was placed in the lateral decubitus position. A posterior superior portal was established percutaneously and a diagnostic arthroscopy was performed. During the diagnostic arthroscopy, a Kim lesion was seen as well as some soft fibrillations on the posterior glenoid. A low anterior portal was created and a shaver was utilized for gentle debridement. The labrum was repaired with an elevator through the anterior-inferior portal. The arthroscope was placed in the anterior superior portal and mobilization of the posterior labrum was performed. The mobilization was carried out from the 6 o'clock to the 11 o'clock position. A shaver was used to create a bleeding margin. Fixation was then started. A 7 o'clock portal was created percutaneously and a 7 mm cannula was placed in the portal. Drilling occurred at the 6 o'clock position for a knotless all-suture anchor. A pinch tuck simple configuration was done with the suture lasso device. The first pass was through the capsule and the second pass was through the inferior labrum. The suture was then shuttled to the labrum. The suture was preliminarily tensioned. The same technique was then performed at the 7 o'clock position. A drill was used and the suture was placed. A capsular shift was performed to mobilize the PI-GHL from inferior to superior. Pleats of tissue were mobilized approximately 1 cm off the glenoid rim, about an hour lower on the clock face. The sutures were preliminarily tensioned and then docked out of the anterior portal to avoid tangles and allow for later retensioning. The same technique was also performed at the 8 and 10 o'clock positions. The sutures were retensioned and then cut short. Here is an image of the final construct with the suture anchors placed at the 6, 7, 8, and 10 o'clock positions with the sutures cut short. Final stability was then assessed and the portals were closed. The posterior portal can be optionally closed with 0 PDS suture after final tensioning. Here is a post-operative rehabilitation plan by Dr. Waterman. In weeks 0 through 3, movement is only done in the wrist and elbow. In weeks 3 through 6, partial range of motion is started, but no adduction of the arm is allowed. In weeks 6 through 12, weights are added progressively to previous ranges of motion, and 20% adduction is started. In months 3 through 12, range of motion is added as tolerated, with throwing starting at 4.5 months. Thank you for your time.